Let's get it started. I'm Alex Smith. I'm a UCSF. I'm a palliative care doc and a researcher and do some bioethics stuff with Greenwall Foundation. I'm a blogger at Jerry Pal with that guy on the end, Eric Wadera. Vijay and I were joking earlier that on my tombstone it will say, he kept his remarks brief, he was a harsh moderator. So I'm going to stick to that. Here are my brief remarks. After my dad was diagnosed with glioblastoma multiforme when I was in medical school, both of my parents became staunch advocates for physician aid in dying in the state of Michigan. We had Tim Quill over to my house for a rally. I wasn't able to be there because I was in med school in California. But since training in palliative care, my position has shifted quite a bit. Many of the patients I've cared for who have asked me to help end their lives, when I've treated reversible sources of suffering, those requests have gone away. I've also witnessed this issue becoming a wedge issue within the palliative care community. We're a community that's united in our zeal and mission, right? And yet nothing divides us, it seems, like this particular issue. I've also been aware that many within the palliative care community have worked really hard to distance ourselves from being the, quote, death doctors, right? And that we're much more about how to live each day as good as it can be and focus on quality of life and the living. So for these reasons, I've mostly stuck my head in the sand about this issue and hoped that it would go away. Well, it hasn't gone away, and now it's the law. And so my own personal deep ambivalence doesn't matter as much anymore. Now it's time to figure out how can we move forward from here. Our palliative care community is faced with a number of pressing issues that I hope some of the panelists will address. How close do we in palliative care want to be to this issue? How close should we be? There's been a lot of talk about how we need to educate clinicians who are not palliative care providers about how to respond. Who's going to do the educating? Who's going to lead that response? Will it be left up to individual institutions, or should there be some sort of statewide effort? How will we address the tremendous diversity in California that distinguishes it from other states where physician-assisted death is legal? I'd like to introduce our three panelists. Briefly, they can say more about themselves if they choose. Vijay Pericoil, sitting to my left, is at Stanford and the Palo Alto VA. She directs the Palliative Medicine Fellowship Program and has a strong interest in meeting the needs of diverse populations. Greg Vandekieft is System Lead Physician for Palliative Care for Providence Health and Services, which includes 34 acute care hospitals and over 200 ambulatory care clinics in California, Oregon, Washington, Montana, and Alaska. He practices inpatient and palliative care in Olympia, Washington. And he co-chairs the AHPM Public Policy Committee and previously chaired the Ethics Interest Group. Eric Wadera, sitting on the left, is with me at UCSF in the Division of Geriatrics and practices clinically with me at the San Francisco VA. He runs the Palliative Medicine Program at the VA and directs the Geriatrics Fellowship, serves on the Ethics Committee, and is a newly elected board member of AHPM. We're going to start off with Vijay. We'll have 5 minutes for remarks, and then we'll take some questions.
So it's really an honor to be here and to have so many leaders in the room and to learn from you. So part of what I thought I would do is in Stanford, and I'm sure we have this everywhere else, we have an RIP, which is research in progress, but it's actually RIP where people come to rip your research. And so part of what I'm doing is a leap of faith here, sort of presenting some of our data to talk a little bit about what Alex was saying earlier. There is definitely a branding issue, and those of us in palliative care are particularly sensitive to this branding issue because we are already seen as the death squad. And so we don't want to become really all about palliative, all about physician-assisted death. And so there is definitely that, and that's on one side. Then the other point that I have is, as a physician, I think we do participate in a lot of deaths that we don't intend, right? When you look at medical errors and all the other things that we have. So that's the second axis I think about. And then the third one is hubris, a little bit, which is in medicine, where we feel like we have evidence-based practice and that actually determines what is right and what is wrong, and somehow we know it. And when anything is a little outside of what we think about is, then we become a little judgmental. So, and I'm talking about me, I'm not talking about you guys. So that's what I'm deeply aware of. So with that, let me just quickly go through these slides just to give you sort of a little biopsy of what we've been doing. without belaboring the point, I think this experiment, which has been predominantly in somewhat monochromatic states, is now in California, which is a plural state with a majority minority. And what that means and how that plays out is going to be very interesting. We started this about a year ago in the effort of bringing the patient's voice to the table, where advance directives is again something that the doctor or a social worker dispenses. And so we did a lot of effort in trying to make advance directives over the counter by having patients take a voice in there, what they wanted for their care. And as we started talking about it, they started talking about aid in dying. And so that's how we started this project almost about a year ago. And these are our trigger questions, basically asking about spirituality, and then asking the question from the Massachusetts ballot measure, which is it acceptable, and how are you thinking about this, and have you completed your advance directive? This is a much larger project, but I'm just showing you the sausage as it's being made. So when you look at the gender, it's 50% male and female, but this is probably the most telling one. And this actually reflects the ethnicity of the state, where you can see it's a majority minority population. Latino, much more in California, much lesser in Hawaii, and then Asian, 215 in California and 386. And about 70 or 80 of them were actually native Hawaiians. So that's where the data I think is most compelling. And here I've given you sort of the marital status, education level. The reason to actually look at these numbers is, don't even worry about the numbers, as much as there is formal education, no formal education, ranging all the way up to graduate and professional. And based on what we've heard about in the other states, we expect that this is the population, right? The graduate Caucasians who are going to be asking for this. But then this is like sort of the Donald Rumsfeld unknown, right? So we'll have to figure out how that plays out. So here is what our study showed. Majority of Californians and Hawaiians were supportive. Again, it's already the law in California, big deal, right? We know they support it and it's the law. But what we are actually hoping that our work will do is help inform Hawaii, which is also a diverse state, but a little different from California. So that's the first point. And then the second one is, in terms of completion of advance directives, about 4 in 10. Actually, if you're being very stringent, it's about 3 in 10, right? In California and Hawaii, those are the people, at least in our study population. And we worked hard to make it state representative, and we are getting more data as we speak. But that's where we are, and this is sort of the results, which is, in looking at the patients we have so far, about 1,000 or so in California, about 800 or so in Hawaii, and then doing some fancy statistics, we actually verified it twice by doing both recursive partitioning as well as stepwise forward logistic regression. The 2 factors that came about are religion/spirituality and age. So let's have some guesses. Who do you think was more in favor of assisted death? The most religious or the least religious? Spot on. And what about age?
Older.
I heard both. Older, younger?
Older.
Older? Okay. So it's usually the young, old. I think in looking at the Oregon data, and we have experts here, I saw that the average age was 72 in Oregon. And so the way I look at it, I'm a geriatrician. So this is truly a geriatrics issue, and it's actually an ethno-geriatrics issue in California. And it's going to be a highly educated population who's going to ask for that. So with that, I'll stop here before Alex has to
Perfect. Thank you, Vijay.
So the reason I have this particular slide here is we have to address at least some of these languages and some of these cultures, and that's going to be sort of our intent.
Yeah, terrific. Thanks, Vijay.
I'm Greg Vandekieft. As Alex mentioned, I'm from Olympia, Washington, but part of my work is as the system lead physician for Providence Health and Services, a system lead physician for palliative care. Providence is a Catholic health system, was actually a fairly outspoken opponent of Washington's Death with Dignity Act, and so practicing in a state that has a Death with Dignity Act for an employer who was very clear we will not be a participating organization really helped shape a lot of my approach as a clinician and as a policy person. One of the other things I do is I co-chair the American Academy of Hospice and Palliative Medicine's Public Policy Committee, and we are currently undergoing a fairly robust process of revising the current position statement on physician aid in dying, which was actually written in 2007, and also developing some materials to distribute to our members to help guide them in responding to requests. So how relevant is this? I'm only about 40% clinical these days, but within a 2-week span this fall, I had 4 very in-depth conversations when patients brought this question to me. 2 in the inpatient setting, 2 in the outpatient setting. And so, yeah, this is very relevant. The Washington experience, both in how we crafted the law, what our law says, is very parallel to Oregon. If you look at the data that have come back, and our data is not as rich as Oregon's to date, very, very similar patterns. About 50-50 men and women, overwhelmingly Caucasian, overwhelmingly educated, and overwhelmingly from the west side of the Cascades. What's interesting and didn't come up in the previous panel is there are some studies that look at how many people who bring this topic up actually follow through. And of every 25 people who ask a question to a hospice social worker, to a chaplain, to a physician, ultimately only about 1 will ultimately ingest the drug. And part of my mission in my work is we have to address all 25 patients. We can't get so hung up on the 1 in 25 that we do not provide the best possible care to those patients, all of them who ask. And so from a response standpoint, you think about both organizational and individual interests. Working within an organization, we needed to develop policy. How do we provide guidance to our frontline staff, the hospice nurses who are in the homes when the question comes up, the primary care physicians in the clinics when the question is raised? And so having a clear policy that provides that type of guidance is critical. Our approach right now, our policy is probably less valuable than they've developed something called operational guidelines that gets through, and this is really written for the frontline hospice staff first and foremost, how to respond to the request, if they elect to follow through, what is allowable, what is not allowable. The main thing that's not allowable is they can't materially participate, can't be present at the time of ingestion. This took a couple of years to really reach a point of equanimity, if you will, because early on it was like, well, once they ingest it, they've gone against our therapeutic understanding, and you shouldn't participate in any way, shape, or form. Hospice nurses had a fit. You will not convince me to abandon my patient in their time of greatest need. And the system responded. They listened, they went back, they revised policy. So don't expect your first draft to be the final draft. This is very iterative, and experience will drive multiple step backs, revisions, and refinement over time. Providence initially wanted to push a just say no mindset, and we pushed back and said, let's focus instead on all that we just say yes to, because again, 24 out of 25 people who ask about it will not ingest. If we just say no, we're only going to respond to that one, and frankly, in a rather unhelpful manner. And so I think about my late friend and colleague, Stu Farber from the University of Washington. We developed a series of role plays. Helene Starks is very involved in this as well, where we would actually work through this with clinicians. We intentionally developed some less than optimal responses. A person would ask in the role play, and I would say, I really want to be there for you, but I work for Providence, and we're not a participating organization. I'll do everything else, but I can't. You shut that conversation down right away. You know, that role play, the audience picks up on it. Another is very technocratic. Well, if you ask, you have to ask verbally, you have to get it in writing, you have to ask again in 15 days. Doesn't get to the issue. On the day our law took effect, an elderly woman said to me, "Doctor, I understand there's a new law that if I want, I can ask and you'll write a prescription so I can end my life with dignity." I had this little Animal House angel on the shoulder moment as I envisioned Stu Farber talking through me, and it was, you know, that's a really important question. I'm so glad that you brought that to me. Before I answer the specifics, what I'd really like to learn more is, what led you to bring that question up? Is it okay if we talk about that first? And one of the things that we emphasize is that last phrase, is it okay if we talk about that first? She has the agency. I'm really handing it back to her how this conversation is going to proceed from here. And part of my take on that is what I said was important. How I reacted was equally important. She's reading me. She is looking to say, how are you as the doctor I'm interacting with? going to respond to me in this important time and with this important question. If my body language, my choice of words, I see Alex moving, is going to shut the conversation down, then
Speaking
of shutting the conversation down.
Thank you, Greg.
Notice how I move the microphone. I'm Alex's doppelganger. So quick show of hands. How many of here in this room are hospice or palliative care healthcare providers? Okay, a couple. So I'm just going to mainly focus on what is the role for hospice and palliative care clinicians when it comes to this law, and how should we be involved in our institutional policies and developing of them, and what else is our role? So how should we be involved? I think if there's one word, intimately. Because a lot of people, really everybody in this room is experts, more experts than anybody else who is outside of this room, basically, on how to respond to these requests, both from a personal and an institutional and professional standpoint. So the three things I'd just really like to briefly talk about in honor of Alex is really being intimately involved in creating our own local institutional policies on how to respond to patients who ask about this. And again, not just like the bureaucratic part, but actually how do we teach our providers, our healthcare providers, all of them, how to respond to these requests in a professional way that also takes into account state law and our own institutional policies. And I think the other important part is creating policies where there is access to hospice and palliative care, whether it be mandatory or highly suggested or really recommended palliative care or hospice referrals, I think is something that we can talk about for the rest of today. I think we should also be talking about increasing access to palliative care. I think talking about rural areas. I work at the San Francisco VA. Our catchment goes up to the very Northern California border. And really where we see the most needs are actually in those areas. Clear Lake area is one of our biggest referral sources for our palliative care team. The need there is great. The access there is exceedingly limited, except for some novel programs in the Northern California area. And the last thing is improving workforce. And I'm going to recommend one thing that everybody in this room should do. So again, from an institutional policy, whether or not you're for or pro this, whether or not you would or would not actually prescribe a drug, whether or not your institution will or will not prescribe or let you prescribe a medication or even refer patients to people who would, I think it is incredibly important that everybody in this room be involved in creating the policies for your institution. Again, not just whether or not you should do this, but how do you respond to the requests, just like Greg was talking about. And I think that is probably the most important thing, because that is the 24 and 25 patients that we will see, what they truly need. Access, increasing access to palliative care. And I think, this is the big issue in palliative care. It is an inpatient specialty where the vast majority of palliative care occurs. This is an outpatient issue on the whole. How do we actually increase outpatient palliative care in creative and novel ways, especially in rural areas, so people have access to the key kind of consultants who can help? And this is not just palliative care, but even hospice. Hospice in rural areas. There's some places where there is no access to hospice. Sometimes it's volunteer hospices. And how do we actually improve access there? And the last thing is thinking about workforce. How many of you here have heard of the Pachita bill? All right, everybody should be raising your hand on this one if you agreed with the initial statement that access to palliative care, access to this workforce is actually very important. Pachita is P-C-H-E-T-A, Pachita. I know it's a terrible acronym, but it's Palliative Care and Hospice Education Training Act. HR 3119. It allows for palliative care and hospice education centers, academic career awards to increase expertise in palliative care, career incentive awards to get interprofessional individuals better training and expertise in palliative care and hospice, federal support for research and training for non-physician providers in improving their palliative care expertise. if we really want to improve access to palliative care, if we actually want to provide those 25 out of 25 people the ability to address all of their needs, this bill is mandatory. So I just would like to advocate, you can just Google PCHETA, talk to Greg or I throughout the breaks today to talk about the need for congressional support, especially if anybody here lives in an area that is more Republican leaning. We could definitely use support from your representatives. Yeah, I will end there.
Terrific. So we have about 20 minutes for questions, and I'd like to try to get through as many of your questions as possible. So I'll call on people. I see one person standing up over there. If we could have the mic. And please introduce yourself.
Hi, Dr. Paul Schneider from the VA in Los Angeles. So there's a federal law that prohibits use of federal tax dollars for either doing physician-assisted suicide or assisting in it in any way. And I'm wondering if in all your experiences, obviously Eric is not doing it at the San Francisco VA, but for instance, some of the research that was discussed, could that be federally supported at all? Can Medicare ever be billed for anything related to it? Those are some of the concerns I have.
I'm not going to answer the question as much as ask more questions. There is also the new VA Choice Act, by which a veteran who's 40 miles away from the VA facility can get a card and access care in the community. So who's going to police what happens there? And is that the best use of how we might provide care for veterans? So actually, it's a really cloudy area, if you think about it.
But I'm not so much talking about the care of veterans as the care of any old average American. If we're prohibited from using any federal dollars in the care of any American as it relates to assisted suicide, how does that impact all the work you do?
So I believe it's restricted to for veteran. So like in the VA system, I cannot actually prescribe or refer patients, so I can't be involved in the process. I think the key thing that we're trying to make sure all of our providers understand is that doesn't limit our ability to respond. Is that even in institutions, and again, this is not just a VA issue. If you're in an institution that says that you cannot do this, we still need to develop policies on how to respond to these requests.
Does anyone in the audience know, Elizabeth, can we have the mic over here? This question about research funding. Here you go.
I apologize. And please, right? I mean, we assume that we're protected by the law as it exists in our state, and we provide care. Clearly, almost all of these patients are Medicare patients, so they are being funded by the federal government in terms of their health care. And in the same way that we also bill for advanced care planning conversations, I challenge them to come find me. I'd like to have that conversation about whether or not that's actually, care that the government should be paying for, right? So I don't know if that's what you were going to say, and I'll
Katrina,
just pass the mic to you. But
Yeah, so I'll just speak a little briefly about Oregon. Of course, the patients who are involved with this are terminally ill patients by definition, and so there's a huge range of care that they're getting up to the point the prescription is written. So it's even a question, what if this is related to the act or not? We, of course, Medicaid is a federal and state match, et cetera. And because the federal dollars can't be used, we work with our Medicaid agency to back out the federal dollars so that the Oregon dollars or tax dollars are the only ones that are paying for Medicaid patients who are participating in this. But again, if you think about, again, the way that we've interpreted in Oregon is that the majority of care that's happening, all of that needs to happen, and it needs to continue, and there's a whole billing process. That the very specific things around what's allowed in the Oregon law really are the steps to prescription is written. The consultant may be an extra, or the psychological evaluation, but those are also happening as part of end-of-life care, back to the 24 out of 25 patients. So again, from our standpoint, we have not heard any pushback from the federal government about the way we're handling it, including this backing out the federal funds from our Medicaid.
Thank you.
You're right about Medicare, but a lot of them, but those patients also have Medigap insurance, and my understanding is that some of the patients are then paying for example, the medications privately and aren't even being billed insurance. So.
Thank you, Katrina.
Yeah.
Greg, you had a brief
Yeah, and I
response?
would just simply say, practicing within a Catholic health system, I have felt no constraint whatsoever on my ability to have the type of conversation I would have in any other setting. And I would bill these things to Medicare based on the underlying condition. What I can't do is I can't complete the documents and I can't write the prescription. But in terms of the conversation and the therapeutic relationship, I'm not constrained in the slightest.
Two quick questions, one in follow-up. Do you then refer to someone who can on the outside, and does your policy for your hospital cover that? And then my main question is that I'm a primary care physician, a family physician at Stanford. Hi, VJ. And
What's your name?
Dr. Catherine Forrest,
Thank you.
also from UCSF prior, so thank you for being here. One of my interests and celebrations is that palliative care and primary care are at the table on this in California, looking at how can we increase access through joining forces. We know that we need to integrate, and looking at California, looking forward to Washington and Oregon, at the impact was actually increased use of hospice, palliative care, starting these conversations, and then really looking at who is at the table, the nurses, advanced practice, physicians, social workers, and then training. And I'm curious whether or not in our efforts we can look at how we might train together rather than in our islands, and what the experience was in other states in training in bridges as opposed to in islands.
Well, just first responding to the referral question, that's also been a work in progress. Early on, there was a lot of skittishness about any form of reference to Compassion and Choices, which is the main organization who helps coordinate volunteers and others. Over time, that was reframed to say, if we're referring for the purpose of comprehensive counseling for the full range of options at the end of life, Compassion and Choices provides that. And so they are now included in the authorized groups that I can refer to: State Hospital Association, County Medical Society, Compassion and Choices. So even if I'm not a participating provider, I can facilitate or help the patient achieve that if that's what they choose to do.
So to respond to Dr. Forrest's comment in terms of can we all train together, I think one of the main stakeholders, in my opinion, that we typically tend to forget is the patient. This is one situation where the patient has to initiate the request, and in our training, in our priming, I think it's absolutely important to have that. I've already had two cases. Sandy True, who's one of our attendings, was telling me about how she got a call about a patient who took 5 times the dose of Wellbutrin and was admitted to the ICU and was seizing. I heard about another case where a patient took like 60 pills of Tylenol because now PAD is official, and ended up dying. And their death certificate is actually going to say suicide. It's not going to say the underlying cause. And so I think it's incredibly important that we educate patients and families.
My name's Katie Butler, and I'm a non-medical person. My question has to do with the sort of an ethical question, which is, my understanding was that if a physician felt morally obligated or institutionally obligated not to participate, that there actually is a responsibility ethically to refer. And am I wrong about this? Where does this place the patient if their doctor won't even refer? Is there an ethical conflict between the institution saying you can't refer and the need of the patient for a referral?
That's a fabulous question. Again, I work in, my clinical work is mainly at a federal facility, so we're not on state grounds. We are trying to get clarification what a referral is. We strongly feel that giving information out to patients is not a referral, and giving information to potential resources is not a referral. I think that's kind of how we're thinking about what to do to get people the access that they want in an institution that does not allow us to participate in meaningful ways, outside again of responding.
I am Jeff Mariano from Kaiser Permanente, Southern California, palliative medicine attending. A quick question about the role of bioethics and in situations where there is, from an initial assessment, possible coercion or other factors contributing to the patient's decision. Are there any systems in place? That's one question that have been created. And then the other one is to address the moral distress of some of our colleagues, programs or other things that are in place, because in our group, we are 10 palliative medicine attendings at Kaiser West LA, and only 2 of them would be okay with writing a prescription. The other 8 are not in agreement. So there is, even within our group, again, palliative medicine trained, also just some differences in opinion. And so I was wondering if any of you guys could comment on that.
I would always say when you face resistance, respect the resistance and get to the underlying meta-level questions. That's in terms of the providers. And then in terms of the patient's coercion, I'm being provocative here. Medicine is all about coercion. Eat well, get exercise, do this procedure. So we are not outside of coercion. Everything we do is coercive. It's all well-intended, and it's matriarchal, patriarchal, beneficence, and all that, but that's what it is. So I think the first thing to acknowledge is that's what we do. We talk our patients into things that we think are good for them that may or may not be. And so that is a pervasive issue, and it becomes a delicate, sensitive issue in this case. So obviously, individuals' issues are individual issues.
Was your question about coercion from other family members to this patient? Anyway, Greg,
Dr. Lagers first.
And please correct me, because I may not know the Oregon law quite as well, but I did want to commend California for the phrase within your law that says that the patient must meet with the attending one-on-one with no one else in the room except an interpreter. I do think that was an oversight in the way that the Washington state law was written, and I think that is only one small step towards ensuring there's no coercion, but it's an important one.
I've worked with multi-ethnic families where telling a patient to speak alone with the physician is actually pretty terrifying for the patient or family-wise unacceptable. And so I think in that too, we need autonomy. If a patient feels like there is a family member that needs to be there, maybe they need to spend 10 seconds with the physician saying, I'm alone, I want my family member and the interpreter, so I'm going to go out and get the family member, and that's my autonomy. So I think that's going to be a little bit of an issue.
I'm not familiar with systems in terms of bioethics consultation or anything like that, but similar to any scenario where you're dealing with a difficult situation, there ought to be a low threshold and there ought to be wide access to the bioethics or the clinical ethics consulting process. It shouldn't be restricted to just physicians, for instance, just like most ethics consult services are set up. In terms of the moral distress, I'll just reference some of our process, which was our hospice teams in particular struggled, and the moral distress ranged from nurses who strongly felt that this is a patient's right and how dare Providence interfere with the person's civil liberties, to people that said this is morally wrong, I cannot participate in any way. We had a number of meetings, everybody together, including mission leaders from the system office in Seattle, and spent a lot of time in well-facilitated conversation. That didn't resolve all the moral distress, but it became increasingly to the margins, and people over time really felt like they'd been heard, been respected, and that their points of view had been integrated to the organizational approach. Those things went a long ways, and then when they come to the individual clinical encounter, they feel like the system has their back, which again really diminishes the moral distress that they would have experienced without that feeling of support.
And I just want to add one more thing, is that while I don't think this is going to be an inpatient hospital issue as much, 1 out of 4 Californians will die in a nursing home. The moral distress that we talk about is not just limited to the prescriber or the pharmacist. It's to the nurses. It's to everybody involved. And I don't think we have a great handle on how to actually do this in an institutional setting like a nursing home. What's the current percent in?
4% in Oregon, did you say?
So getting a better handle of what actually happens there, how are nursing homes actually making decisions, whether or not they're going to participate, and how are they including all staff? Because the distress, I think, is just going to be that much higher in those settings.
We have about 7 minutes left. I want to get through a couple more questions if I could.
So Eric Rowland, UC San Diego, palliative oncologist. A question I have as a physician who does have an outpatient palliative care clinic is what measures are going to be in place as we track these cases over time to ensure the anonymity of the physicians that are prescribing them?
I don't know if Peter, if you might be able to answer some of that from how you've done it in Oregon. I know in Washington they do not readily make available the names of the docs who are working in a volunteer basis with Compassionate Choices. They don't want people picketing in front of their clinics or posting their home address online and things like that.
Let me elaborate on that some. I'll stand up. I don't know. It's just kind of what happens when you're the first, I guess. I was found out. However, there is no way for any information on who practices, who participates in this, for that to become available to anyone outside of the medical care system or the family member. So a family member can say, "Oh, Dr. So-and-so did this for our family." Or a colleague could say to his colleague, "Incidentally, I got this referral from this other person." So that's the only way that any kind of that sort of information would come out. Honest to gosh, I was terrified that there was going to be firebombs coming through my window and pickets in front of my house and stuff like that. I lost 2 patients who both came back. Surprised me, they both came back. It turns out to be less of an issue in real life than it feels like it might be. It was frightening, but it sort of went away.
I just want to add, and I think that too should be opt-in versus opt-out. The physician should be able to say it's okay to publicize versus not. So it's like true autonomy.
Katrina, you want to say?
I'll just make a quick comment, but in Oregon, same thing. People do want names of patients or physicians or whatever, and we do not release. Again, we got a legal opinion about kind of our role that these data, we do protect confidentiality, obviously the medical confidentiality of patients, but of physicians as well. But again, in Oregon, there are people who have self-identified. We know that here in California. People self-identify as either patients who are participating or advocates or physicians. So we don't control the media or the press, but again, the legal opinion that we have is that people are not going to get names of participants from us.
Let's try and get another question if we could.
I am Daniel Pound at UCSF in Geriatrics and Family Medicine. I work with a nurse practitioner and social worker in my office, and many of my patients who are terminally ill have hospice. I'm putting myself in the shoes of a person in private practice by themselves with a patient who refuses to engage in hospice, but asks about this, and wondering how you share the responsibility, especially if somebody has 15-minute appointments, because the law does mandate many important things that have to be reviewed with the patient. So I'm interested how people have done this and how people envision, is it a team effort, or is it all falling on the physician to have these conversations?
I think it's especially challenging in the setting you described of the small independent practitioner, because certainly groups like Group Health Cooperative have requirements for social workers to be involved. I'm not familiar with any system out there to provide interdisciplinary support to the small solo practice type setting beyond the hospice interdisciplinary team. And particularly, as you were pointing out earlier, Michael, the rural counties don't have access to palliative care teams, so it's going to be a challenge.
So Pete and then Elizabeth.
So I'll just say that that was me, and you give away a lot of time because you have to. You can't not decide to do that, and you use the resources that you've got, and it turns out that's who's ever around the patient. You call everybody, and make sure that everybody thinks it's right, and if they don't, then you don't do it. There is a consultation service available nationwide through Compassion called the Doc-to-Doc program, so you can call Compassionate Choices and get advice if you want.
I know that this doesn't feel good, but I think if you're participating the way the law is written, you are certifying that the quality of the information those patients got, and that you did cover all those topics that are mandated. And so I think you have to make the time, unfortunately, and it falls to you. I I was hoping also to just take this opportunity to raise an issue that, throughout all this, I've never once been in a situation where this was used as an opportunity to educate providers about suicide. So, in the terminal cancer populations, the suicide rate is about 2 times the normal rate, the background rate, and there's much in the overlapping demographics, older white males, and I would just also say that if you can at the same time think a little bit about how your institution will address suicide, which was raised, but not, we didn't get a chance to delve into it. I think that makes sense because we don't always have robust processes to identify people who are at risk of suicide, let
Thank
alone
you.
physician assistants.
We have 1 minute left, and there's a hand that's been up here with a bracelet. That's all I could see. There you go.
I like my bracelet too. My name is Paula Goodman-Cruz. I'm the bioethics director for Kaiser Permanente, Southern California. I had a question about decisional capacity and whether or not, in your experience, that your providers have needed assistance in assessing that. Would you do anything different in terms of your workflow, training, clinical pathways, and also as it relates to decisional capacity and the diagnosis of depression?
I can say that decisional capacity is not a static thing, meaning someone can have a decisional capacity and then you give them the script and they lose decisional capacity. Do you go and take it back? So it's something, people talk a lot about depression, right? Clearly, if they're depressed, you can't really give it to them until they're cleared. But decisional capacity is so much more nuanced.
I would also say, as a person who does a lot of training with residents, med students, there's not a lot of focus on decision-making capacity in training for all healthcare providers. So it's desperately needed, and it is a point of concern. And again, thinking about ways how we can actually teach providers not just at one single academic center or one institution, but how do we train all healthcare providers how to assess decision-making capacity, because it's not something that is often done well.
That's great. I want to take time to thank our panel.